vitamin D and women's health, I need to be practical, not to be theoretical lecture, okay? But all of us know that vitamin D is very common and is available in the pharmacies, in the supermarkets, and all patients or come to our clinics and bring vitamin D from their bags to you. Should I take this? Should I take this dose, this form, and whatever? So it's well known for all people. So why we come here today? We come here to highlight the importance of the vitamin D for the women's health and the recent recommendations of the societies concerned with vitamin D. We will discuss vitamin D nature, mechanism of action sources, vitamin D paradox, functions, daily requirement, testing, vitamin D deficiency manifestations and management, in addition to some conclusions. So we know that vitamin D is one of the lipid-soluble vitamins, which are A, D, E, K, ADIK. So what's the importance of being lipid vitamin? It's lipophilic nature. It should be given in a fatty diet. So this is the first message from pharmacology to us as clinicians. We have to give the patient vitamin D in a fatty diet. This is important, not to be given on empty stomach. And the second point should be given in the lunch or the morning, not evening, because some studies found it has an effect leading to insomnia. So it's either morning or at lunch with some fat, because it distributes in adipose tissue and fat. This is the first pharmacologic point for us as clinicians. Second character of vitamin D, it has slow turnover in the body and half time may be extended up to 2 months. So what's the clinical significance of this? I am a doctor, I give the patient vitamin D, I have to know that this vitamin D can stay in her body for 2 months. So don't give overdose. This will lead to toxicity of vitamin D. So these are two important issues regarding the pharmacology. We are concerned with two types of vitamin D, vitamin D2 and 3. 2 comes from plant origin and it is absorbed by the intestine. 3, 90% come from sun exposure, from skin, and 10% from the intestine after absorption from animal source. But unfortunately, vitamin D and 3 are inactive. If you take vitamin D and 3, they are inactive. They are useless for your body. Why? Because they should be activated. And activation, as we will see, occurs in the liver and the kidney as the renal activation or extrarenal activation. But now we have to compare vitamin D2, 3, and active vitamin D. The question is, for clinicians, should we give the patient vitamin D2, 3, or active vitamin D? The logic answer is active vitamin D, because it's already activated, so why not to give it to the patients, okay? But this is wrong answer. Why? Because active vitamin D is good, but has narrow therapeutic window, which means the therapeutic level is very near to toxic level. So if you give the patient activated vitamin D, which is called calcitriol, this will lead to some side effects like hypercalcemia and hypercalciuria. So we don't give active vitamin D for patients, okay? Except in some cases where some active metabolites are not readily produced in vivo, in some exceptions. So now we have to give the patient either vitamin D2 or D3. Which one should we select? We have to give the patient vitamin D3. And if you look to any product from pharmaceutical companies, they mention vitamin D3. Why not vitamin D2? Because vitamin D2 is less stable, shorter half-life, but vitamin D3, longer half-life and more absorbed, and increases the level of vitamin D in serum 5 times more than vitamin D2. So in conclusion, we give the patients as a treatment or supplement is vitamin D3, not vitamin D2 or active vitamin D. As you can see in this figure, I told you vitamin D2 and 3 are inactive. They should be activated in the liver. This is the first activation. And this will produce 25 hydroxy vitamin D. And this 25 hydroxy vitamin D in the liver is very important for us as clinicians. Why? If you write to the patient as a test of vitamin D, we test this, which is 25 hydroxy vitamin D. Why not to test the active vitamin D, which is 1,25 dihydroxy? Because 25 hydroxy, which is calcidol, vitamin D is the most circulating vitamin D in the blood. So we test it as an indicator of vitamin D status of the body. So don't forget that when you write vitamin D, you are not measuring vitamin D2, 3, or activated vitamin D. You are measuring that from the liver, which is the first activation, which is 25th hydroxylation. The second activation occurs in the liver, in the kidney, and this is called renal activation or hydroxylation by adding one hydroxyl group to become 125 dihydroxy vitamin D, which is calcitriol. And there is an extra-renal hydroxylation on activation in immune system in some organs like lungs, prostate, colon, and other. What's the importance that there is extra-renal activation or hydroxylation? The importance that vitamin D is not only important for bones, it's important for other functions of the body. And this is the point where most of the research on vitamin D in infertility, for example, stress, because vitamin D is not only for bones, it is for other functions of the body. What's the proof? This is the first proof that there is extra-renal activation, which is occurring in the immune system, breast, colon, lung, and prostate. So this summarizes the topic of vitamin D. There is synthesis of vitamin D. D comes from the intestinal absorption, vitamin D2 from plant origin, vitamin D3 10% from animal and 90% from sun exposure. After synthesis, it should be activated in the liver and kidney. After activation of the kidney, there is effect of the vitamin D in the body. The main effect of vitamin D, of course, is the bone. So it goes to the bones to have some effect. But this is associated with intestinal effect by increasing absorption of calcium and phosphorus from the intestine and increasing calcium binding protein from the intestine, in addition to its effect on the kidney by reabsorption of calcium and phosphorus, and stimulates the kidney also to make more activation of vitamin D. So don't forget that we test 25 hydroxy vitamin D as a measured storage and circulating form. And don't forget that extrarenal activation is an indicator of the multi-system affection by vitamin D. Vitamin D, when you take one tablet of vitamin D, it will go to the cells of the bones or otherwise. And it will activate the receptors of vitamin D, VDR, on the plasma membrane and in the nucleus. In the nucleus of the cells, vitamin D acts as a gene. So it leads to some genetic transcriptions in the cells of the body. And this is recent research actually on vitamin D. You may be surprised that they found more than 11,000 genes related to vitamin D in the body. So vitamin D is not only working on the bones, affecting different parts of the body. Okay, we have a patient in the clinic. She said that I may have vitamin D deficiency. We have to inquire about the daily requirements of vitamin D. So we have to ask her, do you have good sun exposure? She says, no, I am muhajjaba, veiled. I don't go to the sun, for example. Even not, she has to be exposed to sun for around half an hour, twice weekly, and the hands, the legs, the face, and the arms should be exposed to sun, which is not practical for all of us, males or females, to be exposed to sun for twice weekly for this stage to have activation of vitamin, to have formation of vitamin D3 in the skin. Moreover, exposure to sun can lead to a risk of skin cancer, which is related to many times of sun exposure. And exposure to sun rays can lead to what's called solar skin aging, and of course, overpigmentation of the skin. So exposure to sun is a good source, but it is not practical for us, particularly in modern life. We are not we're living in deserts, we are living in houses, cars, and so on. So it's not practical. Okay, so the patient will say, no, I don't have good sun exposure. But we have to ask her about diet. Do you have good diet, including vitamin D, like animal or plant mushroom, and cereals, animal fatty fish, and salmon, milk, and so on? She says, yes, I eat all these. But we have to know that this source of vitamin D2 and 3 is a very limited source of vitamin D. Cannot afford the body with vitamin D requirements per day. Okay, so we have to ask the community, the country we are living in, is the milk is fortified with vitamin D? Is orange juice fortified with vitamin D? Is yogurt fortified with vitamin D? The answer will be limited countries all over the world have some fortification of vitamin D. So in conclusion, of the sources we asked the patient, we will find that most of the patients will have deficient source of vitamin D. And fortification all over the world succeeded in eradication of rickets, but failed to eradicate vitamin D deficiency. So in conclusion of this part, food and sun exposure are suboptimal methods to maintain normal vitamin D level, and fortification of food products with vitamin D should be increased. We have an important point which is practical, which is called vitamin D paradox, which means that we are living in a sunny country like Greece, like Gulf area, like Middle East, with too much sun, but too much vitamin D deficiency in the community. This is called paradox, okay? Why this paradox? Because I told you that we are living in a modern life. We are not living in a desert and with camels and so. We have cars, we have houses, and we don't have time to be exposed to sun. And that's why this paradox, for example, has been reported in Greece, which is a European country with a good sun, but high prevalence of vitamin D deficiency. Of course, in the Gulf area, here a study from Qatar found the vitamin D deficiency is 90%, despite Qatar is one of the most sunny countries of the Gulf area. So the paradox means that sunshine is an unsafe theoretical source of vitamin D that's not applicable as a practical source of vitamin D, and this is a causal paradox. Okay, we have to talk to the patient that she has to have vitamin D. Why vitamin D? Vitamin D is important for us starting when we were gametes, sperms or oocytes before fertilization, and during pregnancy, during delivery, after delivery, neonates and infancy, childhood, adulthood, menopause, old age, until death. So vitamin D is a good thing for the health of the human being at different stages. But don't forget, we give vitamin D to the pregnant or non-pregnant mainly for the classic use of vitamin D. Don't ignore the classic value, because the patient will ask you, if she is, for example, PCOS, why you give me vitamin D? Don't tell her that I give you vitamin D to improve PCOS. No, this is subsidiary. It's not the main indication. I give you vitamin D because it has a classic function in your body, because it controls calcium and phosphorus homeostasis in your blood. Don't forget, because you are a human being and your bones are active, all the time active, you need vitamin D for the bones of your body. And this is an important and classic indication. So don't forget the main and classic function. We have to inform the patient that if she is taking calcium, some patients say, we take calcium, so no need for vitamin D. Calcium is good for the bones, of course, we know this. But we have to inform her that just 10 to 15% of calcium is absorbed without vitamin D. So vitamin D is important for absorption of calcium. And 1 in 2 females, 50 years or more, have fractured bones, fractured head of femur, and you know, head of the femur is one of the causes of death in old age, whether male or female, due to the complications and sequelae of fractured head of femur. So it has been found in one study, 1 in 2 females over the age of 50 have some fractures in their body. So in conclusion, we have to give the patients vitamin D mainly for calcium and phosphorus homeostasis. Why? Because if the blood shows decreased calcium in the serum due to any cause, parathormone hormone is released from parathyroid gland to stimulate activation of vitamin D in the kidney, and vitamin D will go to the bones to promote bone deposition and at the same time bone resorption. It has dual function. It makes bones and at the same time removes calcium from bones. This is very important to know about vitamin D. Here is a figure of the bone for osteoclasts forming the bone. The matrix is covered by calcium and phosphorus. This is activated by nutritional vitamin D, which is vitamin D2 and 3. And this is important to build up our bones, bone formation. But if there is deficiency of calcium in blood, the vitamin D will inhibit osteoclasts, will stimulate osteoclasts to remove calcium from bones to increase calcium level. So calcium level is variable. If decreases in blood, parathormone hormone stimulates activation of vitamin D. Vitamin D goes to the bones to stimulate osteoclastic activity to release calcium and phosphorus in blood. But if there is sufficient level of calcium, calcitonin comes from thyroid, will inhibit the effect of vitamin D. So there is an orchestra, dynamic action between the osteoplastic and osteoclastic activity to prevent osteoporosis and at the same time to improve hypocalcemia in our blood. There is a dynamic relationship between the bone formation and bone resorption. So these are the main indications of vitamin D: to build up our bones, to stimulate calcium phosphorus homeostasis, sometimes activate osteoclasts, sometimes activate osteoblasts, and so on. But the non-classic functions, as mentioned in recent publication by the Endocrine Society and 6th International Conference on Vitamin D, that vitamin D has definite non-classic functions. Don't ignore that it has a metabolic function, cardiovascular, autoimmune, anti-malignant, anti-infection function. So vitamin D is good and very vital for our bodies. And the same is concluded by this 6th International Conference, more or less. So what's the proof that vitamin D is affecting the gonads, affecting the brain, affecting the heart and pancreas and so on? What's the proof? The proof, I already mentioned that the receptors of vitamin D are found in almost all cells of the body, including bones, including brain, breast, heart, and so on. So the receptors are found elsewhere. The second proof, there are more than 11,000 genes of vitamin D receptor target genes identified in the human being. And the third proof that hydroxylation or activation of vitamin D occurs extrarenal in different tissues. So all these are proofs that vitamin D has non-classic, non-skeletal muscular functions. The non-classic functions are antioxidant, anti-inflammatory, immunomodulator, anti-angiogenesis, and we have a study on angiogenesis and anti-angiogenesis in endometriosis found on the YouTube channel if you need to see it, and also stimulates cell proliferation and cell differentiation. On the pancreas has a very critical and important function. It stimulates insulin secretion from the pancreas and inhibits insulin resistance. So it is good for diabetic people. And you will see now in diabetics, the recommendations that pre-diabetics should have vitamin D high dose as a prevention of progression to diabetes. Okay? And on the gonads, it can lead to steroidogenesis and folliculogenesis in females and spermatogenesis in males. Also, it has some function on implantation and prevention of recurrent abortion, IUGR, and other functions. In PCOS, it has a crucial role by increasing sex hormone binding globulin, which binds to testosterone, and this decreases hyperandrogenemia, and also it decreases insulin resistance, and it is an anti-inflammatory. So it has a very important function in PCOS, and here is one of the studies. It leads to increased clinical pregnancy rate in patients with PCOS. Regarding male, steroidogenesis and spermatogenesis also stimulates a chromosomal reaction. Some studies found it's important for impotence and increases general functions of the males. What about IVF patients? If you are IVF consultant, some patients who are subjected to IVF may have some benefit by adding vitamin D to the protocols. Some studies found it increases chemical pregnancy rate, others found increases clinical pregnancy rate, and others found it increases implantation rate. But these are recent studies, but if you see the last one, for example, increasing implantation rate, it has been combined with different materials. So we cannot conclude that vitamin D alone, because they added myoinositol, melatonin, and lactam, albumin, folic acid, and so on and so on. So we cannot guarantee that vitamin D alone is the cause. But in pregnancy, the story is different. It's well known, well concluded, well evidenced that all pregnant ladies will get benefit from vitamin D. As I told you, classic function, which is stimulation of calcium and phosphorus homeostasis, building up the bones of the mother, and prevention of some pregnancy complications like abortions, like IUGR, like hypertension, preterm labor, preeclampsia, and diabetes mellitus. As I told you, diabetes is well-known risk factor that needs vitamin D. Also, for the baby, it's good for its bones, neonates, and childhood, as I already mentioned. So in conclusion of this sector of functions, we have to say that vitamin D is important for the health of bones and the rest of the body. Bones is the classic, is the basic, rest of the body is subsidiary. It has a definite role in protecting pregnant women from some pregnancy-related diseases. And the Sixth International Conference recently mentioned that it should be joined with or combined with calcium. Regarding the reproduction, the recent review article by Hart on IVF use before IVF found that no solid evidence regarding its role for male or female. So what about the daily requirement? I already talked to you that daily requirements are mentioned by many societies at around maximum 600 international units. So the patient may say, I have good daily requirement. We already mentioned that daily requirements are not got from the normal diet and minimal sun exposure. So the daily requirement is 600 for the pregnant, and when the patient is 70 or more, it increases to 800 international units per day, and the maximal dose for the daily requirement is 4,000 per day. But we have to mention that the diet has minimal percentage of the required vitamin D. For example, here I gave you this example. If the patient says, I don't need medication, I need natural, okay, you have to drink 5 cups of milk per day. Any lady drink 5 cups per day, 5 cups gives 600, which is the daily requirement. They don't drink 5 cups per day. And look to the yogurt, for example, gives 80 international units, which is minimum. Cheese, 6 international units. So the diet is usually insufficient to supply the daily requirements. So in conclusion, daily dietary sources do poorly supply the daily requirements, particularly in pregnant and lactating and old age, of course. So supplementation is required. Another important clinical and practical issue. The patient comes to the clinic, I need to test vitamin D. All the ladies need to test vitamin D. Why? Because one of my friends has vitamin D deficiency. And if you write vitamin D, the insurance companies, oh, you need vitamin D, this is contraindicated. You have to say that the patient has osteoporosis, she has to have densitometry, X-ray to approve vitamin D. So we are doctors now in a conflict between the patients asking for vitamin D testing and the insurance companies who refuse vitamin D as they are anti-vitamin D testing. This is a critical point in our practice. As recommended by the Endocrine Society and 6th International Conference recently here before 3 months on vitamin D, that testing for vitamin D is not universally accepted as a screening test, and this is important for our practice. Vitamin D testing is not agreed as a screening test for vitamin D deficiency, okay? When the patient says, I need vitamin D without any symptoms, we have to inform her that the recent recommendations recommended against testing vitamin D. This will lead to economic problems in the societies. Too much vitamin D testing will lead to loss of money without any indication. So as a basic point, we have to inform the patient sharply that vitamin D screening is not universally accepted, okay? But the 6th International Conference mentions that there is difference between screening and testing. Screening is that you screen the health community to search for vitamin D population. This is not recommended. But they mentioned that testing targeted to high-risk patients of vitamin D deficiency, you can do it. You can order. So how to order for vitamin D? We have to ask the patient some questions regarding vitamin D deficiency. If you suspect some symptoms of vitamin D deficiency, you have to write to the insurance that the patient has the coming symptoms we will mention. Otherwise, it's not recommended to do it just for screening. It's not a screening tool. What about pregnant ladies? Again, in pregnancy is not recommended as a screening tool for pregnant ladies unless you expect that this is ECHO recommendation. Unless you expect that she has deficiency. And here is the summary of the guidelines, and this is Endocrine Society Clinical Practice Guidelines. For regarding the vitamin D level in the serum, if it is less than 20, this is deficiency, vitamin D deficiency. More, this is different deficiency. But between 20 and 30, this is not too much this deficiency, it's called insufficiency. From 30 to 50, this is sufficient or elite, and this is good, 30 to 50. If more than 50, you have to stop giving the patient vitamin D. More than 50 is serious, because if you continue to give the patient vitamin D, this will lead to vitamin D toxicity or hypervitaminosis D. So we work in the margin between 30 and 50. And it has been mentioned in some publications that 20 maintains calcium balance in blood, okay? But 30 is optimal cell health for the whole body, okay? So we work between 30 and 50 nanogram per deciliter. And at 30, in addition to some daily requirements and some sunshine exposure, this will lead to safe and effective vitamin D. Don't forget that we test 25 hydroxy vitamin D, not the active form as I already mentioned. In conclusion, vitamin D screening is not recommended. Vitamin D testing is required in selected cases when you suspect vitamin D deficiency. So we have a lot of patients in our clinic. How to expect that this patient may have vitamin D deficiency? Of course, we know that vitamin D deficiency is too frequent in the societies, as I already mentioned. In a study in Qatar, 90%, and here is 40% and 60% and so on. We have some risk factors in our patients to suspect that the patient may have vitamin D. The first, I classified them into risk factor diseases and type of patient, okay? Diseases, if the patient has history of cholecystectomy, for example, so she has insufficient bile salts, so we have to order for her vitamin D. If the patient has gastric operation, now it's a moda to have bariatric surgery. So if she has bariatric surgery, we can order vitamin D due to deficient absorption. If she is receiving medications like steroids, like antifungals, like anti-scissors, and other drugs, we have to order for vitamin D. If she has liver problems, liver failure or liver disease, because the liver is the first site of activation or hydroxylation. If she has parathyroid problems like hyperparathyroidism, which means all the time hyperparathyroidism will lead to a deficiency of vitamin D, and chronic kidney disease, of course, some bone problems like osteomalacia, osteoporosis, old age, history of fractures and falls, rickets for children, and some granuloma like disorders and some lymphomas. Of course, if the patient has Crohn's disease or malabsorption disease, she is liable to order, we have to order for vitamin D testing. And of course, we have the patients with little exposure to sun, with dark skin, with using sunscreen creams or gels in some seasonal areas, seasonal timing, I mean, without sun, some high latitude, smoking, alcohol, obese patients, pregnant and lactation. You can order for vitamin D, provided you have symptoms of vitamin D as recommended by the societies that without symptoms, don't use it as a screening test. Of course, vitamin D deficiency will lead to imbalance between oxidant and antioxidant, will lead to anemia, reproductive problems, and so on, but without significant or important proof. So we have to suspect vitamin D deficiency if the patient comes with musculoskeletal symptoms, bone pain, myalgia, and so on, and also fatigue, poor sleep, and poor quality of life. This is an indication that you may order for vitamin D, or at least you give her vitamin D if not approved. And we have to know that in the first trimester, if the patient has vitamin D deficiency, this leads to high rate of preterm labor and small length of the baby, as found in many studies in around 20% of cases. So these are the maternal and fetal problems related to vitamin D deficiency. You know, vitamin D is found in different parts of the body, so it has different functions. I told you already discussed the PCOS. So in conclusion, vitamin D deficiency symptoms are non-specific. Diagnosis should mainly rely on clinical assessment, history, and examination, and rarely vitamin D testing is required. Now, we diagnose the patient clinically as vitamin D deficiency or laboratory by testing 25-hydroxy vitamin D. What to do? We have to give her vitamin D. But the recommendations that all females, this is not society recommendation, all women should have vitamin D, simply because of pregnancy and lactation, as mentioned in this literature, and particularly pregnant women as recommended in the societies. So this first recommendation is just one author recommendation. It's not recommended by societies. The societies mention that vitamin D is given empiric without testing for all populations who are less than 18 years. Less than 18 years, we give them empiric without test. For all males or females less than 18 years, this is a recent recommendation. More than 75, and other publication more than 70. And of course, pregnant ladies should have empiric vitamin D, and pre-diabetic people should have vitamin D supplementation. Empiric, without routine, without testing. And this review and recommendation found that less than 18, you can give up to 1,200 international units per day. For more than 75, increase the dose because of liability to fractures, 2,500. Pre-diabetics, you can give up to 1,000 per day, okay? Some studies, 2,000. What about pregnant ladies? These recommendations are empiric, routine, provided, as they mentioned, provided that the patient does not have a cause of vitamin D deficiency. If the patient has a cause of vitamin D deficiency, like defective absorption, liver disease, and so on, she has to be treated as deficiency. What about pregnant? Pregnant, we give them empiric vitamin D without testing. For all pregnant ladies, okay, don't forget, for all pregnant ladies, we give vitamin D as empiric vitamin D supplementation as recommended. I classified the topics or publications into this algorithm. We give vitamin D routine for all pregnant ladies in our clinics. If she is low risk without risk factors for vitamin D deficiency, we can give from 400 to 600 international units per day. If she is high risk for preeclampsia, for abortions, for IUGR, for preterm labor, we can give up to 2,000 international units per day. But if she is at risk of diabetes, gestational diabetes, or has history of diabetes, we have to increase more than 2,000 per day. More than 2,000 per day for diabetics, pre-diabetics, and gestational diabetes. What about patients with vitamin D deficiency? We can increase the dose up to 4,000 per day. Don't exceed 4,000 per day, okay? So this algorithm summarizes the publications. I put the publications in a short tables or short presentation. Here is a recommendation by many societies between September and March should be given to the ladies. WHO recommended 400 international units, NHS 400, and for high-risk patients with liability to preeclampsia, diabetes, severe postpartum hemorrhage, we have to give them vitamin D. Here are review articles and Cochrane reviews in addition to calcium. And this is an interesting study. If the patient has liability to have gestational diabetes, they increase the dose more than 2,000 per day, and when she is at risk of preeclampsia, they give 2,000 or less, and they found that this has a significant effect, and these are 27 randomized controlled trials as a systematic review and meta-analysis. So in patients liable to diabetes, we give them high dose of vitamin D because it increases insulin level, decreases insulin resistance. For patients liable to preeclampsia, it's an anti-inflammatory and inhibits some interleukins. So for patients with deficiency, we can give them according to the clinical situation, according to the color of the skin, exposure to sun, according to diet, according to body mass index, and so on. Here are summary of many studies. I don't have to go through, but for deficiency, we give between 1,000, 2,000 per day as mentioned. And here, don't forget that this table shows that you don't have to exceed 4,000 per day. And this summary is summarizing the studies that if you give routine low risk, 400 to 800, high risk without diabetes, less than 2,000 per day, high risk with possibility of diabetes, more than 2,000, vitamin D deficient patient from 1 to 2,000 up to 4,000 per day, avoid more than 4,000 to avoid toxicity. Which type of vitamin D? We give vitamin D3, I already mentioned. Oral is preferred more than the preferred rule. Avoid intramuscular rule or other rules because oral, in these recommendations, oral is the best and preferred rule. And here this study found number 1 is oral, number 2 injection, and sometimes you give active vitamin D in some chromosomal abnormalities of the genes. And daily use is much preferred than weekly use. Daily use is much preferred as recommended. Daily low dose vitamin D is preferred over non-daily high doses. Timing, I already mentioned in the morning or with meals. What's the duration of use is no universal agreement. This is from publication between 6 to 8 weeks to treat deficiency and avoid more than 50 nanogram to avoid hypercalcemia and hypercalciuria and other symptoms. Some studies found ataxia, dysarthria, confusions, and kidney disease if you exceed 4,000 per day. Can we give 50,000? Some companies come to your clinic with 50,000 international unit. As recommended by the Endocrine Society recently, that daily low dose vitamin D is preferred over non-daily high dose. This is a recent recommendation. And also ECOG mentions that data on the safety of high doses are lacking, and it's better to avoid high doses during pregnancy. As I already mentioned, don't exceed 4,000 per day. If you give 50 per week, so this is more than 4,000 per day. So it's not recommended. Here is, I have to be honest, that there is some studies which highlights the importance of 50,000 per day, but if you look to this study, 67 women only, it's a small study, 36 patients we cannot take conclusions. We have to follow the societies to avoid high dose in pregnancy. So in conclusion, sorry for this long talk, but vitamin D deficiency is a common clinical presentation. Diet, fortification, and proper sun exposure are not always practical. Dietary supplements of vitamin D are easily prescribed, inexpensive, available over the counter. As recommended, empiric vitamin D supplementation is highly recommended in many groups of patients, except from 19 to 74. But those patients, if they have clinical manifestations of deficiency, if they are pregnant, if she has PCOS, female infertility, IVF, menopause, and so on, you have to give them supplementation according to the clinical situation. You are a clinician, so you can expect which patient is in need of vitamin D supplementation. And of course, vitamin D supplementation is tailored according to the patient's circumstances, seasons, delivery, and risk factors. And we, as doctors, we have to think of vitamin D deficiency when the patient has symptoms of malaise, fatigue, muscle pain, and so on. You have to think of vitamin D deficiency, and you have to make health education regarding diet and sun exposure, avoid overdose, and avoid toxicity. And waiting for randomized controlled trials regarding infertility, IVF, and other obstetric and gynecologic uses. Thank you.